All right? Now, I need for you to visualize these things. The unsealed source. Unsealed meaning it's not encapsulated. So PO, right? If you take a pill, it becomes absorbed into your body. It's unsealed, correct? IV becomes absorbed into your body. That's unsealed. So PO or IV is certainly unsealed. Intracavity, especially iodine 131, where you just dump it right into the particular cavity, like the bladder, okay, that's an unsealed source as well. The waste products are radioactive, but once that radioactive isotope is completely eliminated from your body, neither the patient nor that patient's excreta are radioactive. Now, what do I mean by that? Okay, every single drug, every single element in the whole wide world has a half-life. Now, do you all know what a half-life is? Probably not. Okay, because we didn't take, the opportunity to explain it to you in nursing school. A half-life is the amount of time it takes for any given element to decrease its strength by 50%. So let's just say now that we've given you this drug A, okay, and this drug A's half-life is 4 hours, okay? So in 4 hours, I will now be 50% potent than I was 4 hours ago. And in another 4 hours, I will now be 25% potent. Do you understand? I've just decreased by half again. In another 4 hours, I will be 12.5%. In another 4 hours, I will be 6.75%. Do you see? So every 4 hours, I diminish my strength by 50%. That's the half-life. So once, and it usually takes 1, 2, 3, 4, 5, at least 5 or 6 half-lives, at least 6 half-lives, okay, for a drug to be completely eliminated from your system. So if the half-life of the drug is 3 days, then it takes certainly longer for it to be completely eliminated from your system. Okay? So it's really important that you know that, because then you know when this particular patient is no longer radioactive. Okay, as far as you're concerned with a nurse. And also, how to handle the excreta. The sealed source now means that the source of the radiation is encapsulated and is implanted inside or close to the tumor. Okay, a sealed source can be temporary or permanent, and the excreta are not radioactive because it's sealed and it only attacks that particular area right around it. So the excreta and the sealed source are not radioactive. For any implant, any brachytherapy, for any implant, that patient, if she's hospitalized, must have a private room. Okay. Most times, as I said, if a person is undergoing brachytherapy, we do bring them into the hospital. Okay. It's difficult to send them home because you have everybody under the sun that wants to be in and out of the room. Okay. We need to maintain some privacy for her. So private room and bed rest, certainly, particularly if it's a cervical implant. She cannot get out of bed because we don't want that implant to fall out. Okay? We will put a Foley in her. We'll give her stool softness because we don't want her straining. Because if she strains, again, it may pop the cervical implant out. We'll give her bland foods, but we'll give her lots of high-protein foods. Because remember, with chemotherapy, what happens is you lose a lot of weight because you have no appetite. Okay? So we want to give high-protein foods, high-calorie foods, but bland. Head of bed no more than 30 degrees, that's a nice way to go. Okay? And you want to watch for complications. Okay? Now, when I say complications, what I'm saying is vaginal discharge, any dysuria, okay, any hematuria, is there rectal bleeding? Those are complications. And if any of these things occur, you need to tell the doctor. Any foul-smelling vaginal discharge, you need to tell the doctor because she may be coming down with an infection. Okay, she may be coming down with other complications, like maybe we've just, done an oops and hurt the bladder here, or the bowel for that matter. What you've got to tell your patients very, very firmly and very strongly is that they're not to have any sexual intercourse while that cervical implant is in. This is for patients who go home. Okay, though I do have to tell you, I did have a patient who had a cervical implant in, and I'm not an oncology nurse, but I got pulled to an oncology floor. This was years ago. I got pulled to an oncology floor, and I thought, oh, great, I'm going to go home, and I'm going to be glowing in the dark. But I went in to take care of her. Her husband had come in to visit. I went in to take care of her, and I found him in the bed with her, and he was stark naked. And I said, okay, sir, I really don't think it's a good idea that you have sex with your wife at this point in time, because she has an implant in her cervix. So unless you want to irradiate the head of your penis, sometimes you have to, be very blunt. Okay, so no sexual intercourse while the implant is in. And you have to have, and this is an NCLEX question, in every room of every person that has an implant, you must have a pair of forceps. That is in case that implant falls out. You do not pick up that implant with your bare hands. You don't pick it up with your gloved hands. You don't pick it up, I don't care if you got 6 pairs of gloves on. You'll use the forceps. You use the forceps, okay? You absolutely use the forceps at all times. Now, we put the Foley in so that we don't have to worry that every time she pees, we have to look and see if the implant fell out. However, every time she has a bowel movement, we got to do the crap patrol, okay? Because it means you got to look through to make sure the implant didn't fall out. Okay. Each hospital has wonderful ways of disposing. Most times it's that yellow biohazardous bag that says radioactive on it. So you've got to know how to dispose of linens or excreta, that possibly could be radioactive. Let's move on to surgery, the complications of a hysterectomy. If they have a hysterectomy, sometimes it can be radical and can include the vagina. Remember, if your patient is having a hysterectomy done, that you have to tell her that there's no heavy lifting for at least 6 to 8 weeks after the surgery, right? And heavy lifting means no more than 10 pounds. Nothing more than 10 pounds. The other thing you've got to remember also is that if they do a radical hysterectomy, in other words, a total abdominal hysterectomy with a bilateral salpingo-oophorectomy, which is TAHBSO, you'll see that written. If they have that, you need to tell them that they will have not 1, but 2 episodes of menopause. Yes, it's true. The first one's just a trial run, the second one to make sure you got it. Just kidding. No sense of humor, you all. Okay. So we're taking out the ovaries. We're taking out the uterus. When you take out the ovaries, she will undergo biological menopause, particularly if she's only 40 years old. Okay, she will undergo biological menopause. And yes, it's the hot flashes. Yes, it's the crankiness. Yes, it's the everything under the sun that goes with menopause. Okay? Now, once she's gotten over that and mastered that completely, later on in life, when she hits her 50s, she will undergo chronological menopause. So twice she will undergo it. So you need to caution her on this. And right away she will say, oh no. After she's gone through the first one, she will say, oh no. Okay. Nursing care for cancer patients, we talked about this, lots of high protein, high calories, right? And we want to avoid sunlight and exposure. With any form of radioactive therapy, the nurse must follow these principles of time, distance, and shielding. Okay, time meaning the amount of time you spend with a particular patient. In other words, with cancer patients who are undergoing radiation treatment, what you've got to any form of radioactive therapy, it is better for you to actually come in and spend 5 minutes with her, go back out and then come back again later and spend another 5 minutes. That's a total of 10, right? That's better than coming in and spending a full 10 minutes. Okay, so time, distance, and shielding are important things. It's actually better for you to break it up that way. Distance meaning how far away you are from the actual source or from the patient who is the source of radiation. Okay? If you are going to open the door, if you want to ask the patient, what do you want for breakfast, just open the door, poke your head in and say, what do you want for breakfast? You don't have to go right up to her, and say, what do you want for breakfast? So distance is another thing. Shielding is the third, and shielding simply means something or any obstruction that lies between you and the patient. If I put this up, this little plastic sheet up between me and the patient, that's not a whole lot of shielding, correct? If I put this up, which is in this big bundle of papers, that's a little more shielding, correct? If I put the table between me and her, that's even more shielding, okay? And if I put a brick wall up, that's even more shielding, correct? So, bearing that in mind, if the patient has a cervical implant, okay, where would be the best place for you to work with her? From the bottom of the bed or from the top of the bed? Exactly. Okay, because you're following the principles of shielding. Follow? That's an NCLEX question. Okay. Yesterday someone had said, she got questioned on Hodgkin's, on mononucleosis, on all these esoteric diseases. So I said, that's okay, we're going to cover Hodgkin's today. So, Hodgkin's is a malignant tumor of the lymphoid tissues. It's a B lymphocyte problem, not TB. Okay? Hodgkin's disease has to do with the B cells, the B lymphocyte problem. How do you diagnose it? Biopsy. Okay? Biopsy of the lymph, biopsy of the bone, and we can also do a CBC. Signs and symptoms, well, guess what? Night sweats, weight loss, and fever. That's pretty nonspecific, isn't it? Very nonspecific. You've got 4 stages in Hodgkin's. Number 1 is when you only one single lymph node is involved. Stage 2 is when you have 2 or more lymph nodes on the same side of the diaphragm or of an organ. Stage 3 is when you have involvement on both sides of the diaphragm or the spleen. And stage 4 is when there's major involvement of 1 or more organs or tissues. Obviously, you know the staging. Stage 1 is not so severe. Stage 4, the higher a number you go, the more severe the staging is and the more severe the disease process is. The treatment of Hodgkin's includes these 4 particular categories of drugs. Now, you have in your book, I think somewhere where it mentions Mensa, M-E-N-S-A. Now, and I'm not talking the Agency for Geniuses, okay, the Organization for Geniuses. Mensa stands for, are you ready? M stands for mustard-based chemotherapy agents. E stands for estrogen. N stands for nitrogen. S stands for steroids, and A stands for antibiotics. So, M, mustard-based drugs. E, estrogen, actually steroids, okay. N stands for nitrogen-based drugs. S is steroids, and A is antibiotics. So that's what the Mensa stands for. When you are taking care of a patient with Hodgkin's, the most important thing you've got to remember is no rectal temps. You may not take a rectal temp on a patient with Hodgkin's, because you can actually cause a complication here. So you may not take rectal temps with Hodgkin's diseases. There's a non-Hodgkin's lymphoma. Hodgkin's lymphoma is the B lymphocyte, and it is not as serious as non-Hodgkin's. Jackie Kennedy Onassis died of non-Hodgkin's, and it came on very quickly, and it was very rapid. Non-Hodgkin's lymphoma. Okay. When you get non-Hodgkin's lymphoma, that's so dangerous because look at where it targets. It targets the bone marrow, which is where your white cells where your stem cells are produced. Okay, and remember, stem cells come out, they're non-differentiated, so a stem cell can become your hair, it can become your eye, it can become your nose, it can become your rectum, it can become your bones, it can become your toes. So stem cells are non-differentiated. They attack the stem cells. Okay, so it attacks the bone marrow, the central nervous system, your GI tract, the breasts, the testes, the liver. Non-Hodgkin's is infinitely more dangerous than Hodgkin's disease. Colorectal cancer. With colorectal cancer, what you've got is a change in your bowels, okay, ribbon-like stools or tarry bloody stools. Now remember, again, depends on what is normal. I taught a cancer class one time. Like I said, I wasn't, when I first did this, I'm not an oncology nurse, but I teach preventive nursing and preventive medicine. And I was teaching a class one time, and I was talking about ribbon-like stools. And later on, after the class was over, a student came up to me and she said, I've always had ribbon-like stools. Does that mean